So the next topic that we should discuss is what is the difference between chronic pain and acute pain? And we will do this as a group, as a roundtable.
Good.
So,
Okay.
Tom, would you start discussing a little bit what's the difference, or what is acute pain?
So I think that this is a very important discussion because for years the whole chronic pain literature really basically considered chronic pain to be long-lasting acute pain. A lot of scientific experiments had been done using an acute pain model and making conclusions about chronic pain. And physicians also would be surprised, for example, if they didn't find elevated blood pressure or rapid heart rate in somebody who'd had pain for 10 years. I think we know much better now that there's a big difference, but I'd like to outline some of the really fundamental differences. In fact, chronic pain and acute pain could almost be thought to be opposite of each other. I'd like to sort of bring forth the analogy of sadness and depression. Sadness is a normal emotion someone should certainly experience in a difficult circumstance, and if they don't, you would consider that perhaps to be unhealthy, whereas depression is a change in the fundamental structure and chemistry of the brain so that it's a brain disorder. I think it's the evidence at this point is unequivocal that acute pain and chronic pain can be viewed the same way. Acute pain is a very healthy signal. It's a very healthy experience. There are rare individuals who do not experience acute pain at all because they have no nociceptors, and those individuals tend to die before the age of 25. So we know how critical it is to have the ability to sense pain, to learn from pain, so that you can avoid tissue damage. In contrast, chronic pain is exactly the opposite. It is a very unhealthy response and should be thought of just like depression as a disordered brain. So whereas we have acute pain being to maintain health with a call to action, we have a chronic pain, and by that I mean a chronic pain syndrome. I don't mean chronic pain of some type, but the syndrome where the person succumbs to the effects of pain in the long term is truly a brain disorder. And that means, of course, that our approach to the two has to be entirely different, if not almost opposites, in terms of, in the acute pain situation, trying to understand specifically why they're having and how to attend to the specific problem, and in chronic pain, trying to manage how the brain is processing this kind of information.
And one of the things I think that we find is that the patients bring this misunderstanding of their pain,
Right.
making the assumption that we still have to deal at the periphery, for example, with the apparent source of pain. And our task now truly has to be to help them to embrace a new paradigm for understanding their pain that isn't as intuitive as the acute pain model, but it's actually much more accurate.
Right, right. And I think that we all, patients and physicians alike, have that same paradigm in our we bring that to the table. And so it's very important, if you're seeing patients with chronic pain, to have a very thorough understanding of the differences.
Yeah.
So you were saying before that chronic pain is a brain disorder. Would you expand a little bit more there?
Sure. So we know that patients who have chronic pain have a thinning of the cortex, that connections between different parts of the brain are abnormal, and that some of the structures that are intended to reduce pain that ascends to presumably the conscious brain, in many cases are atrophied so that they cannot function properly. There are all kinds of consequences that Jeff will be much more expert in talking about, but some of these include sleep disruption, becoming passive, perhaps even depression and anxiety, that are innate consequences of a chronic pain syndrome and that reflect this disordered brain.
So, Jeff, would you expand a little bit more on the consequences of chronic pain syndrome?
So another behavioral consequence is that patients often develop apprehension about engaging in activity for fear that it will be accompanied by increased pain or even tissue damage. We think about that as the fear avoidance model, where the fear of exacerbating pain causes patients to avoid doing activities that actually may be helpful to them. Right. That often is accompanied by cognitive catastrophization, where patients think the worst, they assume the worst, they believe the worst about any of the activities they're engaging in. They fear the worst possible consequences, that this is going to be just an awful experience for them if they engage in some activity, or it's going to truly make things much worse. Finally, we see that there's a almost universal sleep disturbance. Yes. That may accompany depression. We know that sleep disturbance is one of the criteria for depression, but it also actually could be a consequence from the patient's perspective. They often think of sleep disturbance as being because of pain, and often, frankly, it's because of depression. So in summary then, we have loss of self-efficacy, we have anxiety and depression, we have sleep disturbance, and we have an overall kind of passivity in response to pain that in total leave patients, I think, often feeling out of control. Dennis Turk, one of the prominent researchers in pain, has talked about how pain is not in our body and it's not in our brain, but it's in our lives. And I think we see that wholesale sense of loss of control that makes our patients in chronic pain amplify their pain and attribute that sense of loss of control exclusively to the pain, when it's really this whole constellation of things, as we've seen. And actually later, I think we'll see in our upcoming interaction with a patient that there is catastrophization and self-efficacy demonstrated in that video, and you'll see in a way how this plays out.
Jeff, there are people that suffer of daily pain, but they don't have all the comorbid conditions that you just described. Can you explain a little bit more about that?
You know, that's a really interesting observation. I think we all know people who seem to be handling chronic pain with real grace, with a sense that they're not allowing it to interfere with their lives and their functions in the way that this population with chronic pain syndrome seems to be. And we're just now beginning to study that population more and thinking about this with concepts like resilience, people who are able to bounce back, who are able not to allow pain to drive their function. And this highlights again for us the importance of distinguishing between pain on the one hand and function on the other. Yeah. They're experiencing pain, but they're not allowing it to interfere with their function in a way that then spirals into this whole constellation of problems.
I think that there is a general concept or thought that people that develop a chronic pain syndrome have a previous history of depression. What are your thoughts there?
Well, it's interesting. The literature wouldn't support that. I know that that's been a popular concept. Yeah. But in fact, in the meta-analyses that have been done, it seems that it's very rare for depression to precede a pain episode. It's much, much more common for pain to precede a depressive episode, for example. So it's not that there is a pain-prone personality, which was the old notion, but rather that there are some people who fall into this trap of allowing themselves to become more and more passive and less functional, that then spirals this whole thing kind of out of control.
Tom, do you think that you can try to summarize or compare the characteristic of acute and chronic pain?
So I think it's important to add something perhaps I didn't mention before, and that is emphasized in the small talk I give that sort of sets the stage for this whole course, and that is that pain, particularly chronic pain, is primarily a motor phenomenon rather than a sensory phenomenon. It feels to us like a sensory phenomenon. It feels like the pain is coming from the back. But it's been shown time and again that the parts of the brain that are active in someone with chronic pain and that perpetuate the chronic pain syndrome are more the motor parts of the cortex. For example, if you want to manage pain, you don't stimulate the sensory cortex, which would be intuitively where I would have thought you'd put the needle. You stimulate the motor cortex. So I think if we were to broaden that concept, we would think of acute pain as a call to action. It impacts the motor cortex, and really, if you think about it, that's the point. Get your hand out of the fire. Get your body to the emergency room because you have appendicitis. It's a call to a motor action. But when that call gets presumably repeated over and over again with no consequence, eventually the motor cortex is no longer able to respond, or I'm just making that up. Something happens to the motor cortex, but what we do know for sure is that motor cortex now becomes thinned, and there is an inhibitory component, which may be the equivalent of what Jeff is talking about in terms of the observed behavioral passivity, may in fact have a physiologic basis in the fact that the motor cortex is no longer able to function as it previously did.
Mm-hmm.
Thank you.
So Gisela, let me turn to you and ask you a question about children. So we've talked already about the fact that when you're taking care of kids, you have this added component. There's the parents. And I know there are many studies that have looked at the parents' ability to, for example, catastrophize, or the parents' ability to, their perception of their child's pain differs greatly from their
Correct.
child's perception. And so how would you factor that into this difference between acute and chronic pain, the fact that the parent now may have a whole different perception than the child?
Well, I think that it can work in different ways, Tom, in the sense that sometimes are the parents that are perpetuating the circumstances. I think that often for parents, when the child is sick, they tend to overprotect the child. And then they almost encourage what Jeff was just saying, which is that passivity. Mom will come and bring breakfast to bed, don't go to school. And instead of bringing that child into function, we are fostering the lack of activity. That can happen sometimes. Sometimes it's the opposite. Sometimes the parents realize that the cycle that the child is getting into, the passivity, the inactivity, catastrophization, is not going anywhere, and that usually ends in a lot of friction between the parents. The other thing that the children have different, although I think that in this age that may be changing, is the sleep issue. Yes, sleep is part of chronic pain, but I think that teens are so prone to use of electronics that when they cannot sleep, they take the phone to bed, they take the tablets, they have constantly the blue lights with them, which then increases even more the sleep disorder that teenagers tend to have.
So a more appropriate parental response would be to train coping strategies and encourage resilience, as opposed to kind of pamper and encourage passivity.
Correct. And I always remember what a mother told me one time. She says, I never realized that all what I was doing before was exactly the opposite. Mm-hmm. I thought my daughter sick, I wanted to help her, and the only thing I was doing is perpetuating the disorder.
It reinforces pain behavior, doesn't
Correct.
it? It reinforces exactly the wrong things, where we would hope parents would be encouraging an active approach and working through pain. It's actually encouraging and reinforcing pain behavior.
Correct. Thank you, Jeff. Thank you for all the contributions.
Thank you, Gisela.
And Tom, thank you too.
And thank you, Gisela. Thank you, Jeff. So let me summarize. What we learned today is that acute and chronic pain could not be more different in terms of their fundamental physiology. Acute pain activates the motor cortex. chronic pain inactivates the motor cortex. Acute pain is a fundamental piece of survival, and people who don't have it die before the age of 25, while a chronic pain syndrome promotes all kinds of comorbid issues that result in a horrible quality of life. Some of these issues we've covered include the learned passivity, the fear avoidance cycle, catastrophization, loss of self-efficacy, and sleep disturbance. Also, if severe, their depression and anxiety, true depression, true anxiety can actually be present as well. We've also learned that some of these same issues occur in children, though the situation can be a bit more complex because the parent and the child may have different perceptions of where the child is. The parent may be encouraging the child's passivity, or the parent may be butting heads with the child because they want them to become active, and rightly so. But the ideal situation in the parent-child relationship is for the parent to be engaging the child in optimal coping strategies.